who's just joining us at the moment, we're going to allow you a bit of time to log on. What we know about these Zoom conferences is that people log on just at the time that we say we're going to start. So for the next couple of minutes, we'll just let you log on. My name's Aaron Wood. You'll hear from me in just a moment once again, introducing myself and also today's conference. And we're obviously here for the Aged Care Industry Information Technology Council, and this is our second forum for the year. So please log on, put yourselves on mute, and I'll get underway shortly with some instructions about how today's conference is going to run, your opportunities for getting involved, and just a little bit more about our speakers. So kicking off very shortly, and looking forward to a large number of participants that are joining us this morning from right across the industry, from vendors, all levels of government, providers, and the first forum was very successful in terms of the participation that we saw. So kicking off very shortly, look forward to your company soon. And just while we're waiting there, you can see on your screen, or you should see on your screen, just some instructions for you as we go through this online conference. Any technical issues, you can use the Q&A panel to talk to our technical team, and they'll get that sorted out for you. Any questions during the presentation, submit those on the Q&A function. And what we'll do is we'll pick up as many of those questions as we can throughout today's forum, but any of those questions that we don't get to, we'll answer them after today's forum as well. We'll have some polling questions for you throughout the event. We ask that your microphones are muted, of course. And lastly, today's conference will actually be recorded and made available after the conference event. So if you missed something or you haven't managed to take down some notes, don't worry, we'll get that recording to you very shortly. So as I said, the ACIITC forum will be kicking off in just a couple of minutes with you shortly as we wait for all of our participants to join us this morning. Good morning, everyone, and welcome to the ACIITC forum for today. This is our second forum of the year. My name is Aaron Wood. I'll be your MC for today's online event. I've been lucky enough to MC the last 8 ITAC conferences, and also lucky enough to MC the first forum. We had a lot of great participation in that forum. As mentioned previously, as people were logging in, if you've only just joined us, we've got participants from right across the sector, vendors, all levels of government, representatives from the Royal Commission. So we had a lot of good involvement in that first forum, and we're expecting the same again this morning. You can use the Q&A function to highlight any technical issues that you might have, and I can see that that's already rolling in here. We've got lots of people saying good morning. Please feel free to jump on there and say good morning if you wish. The Q&A function will also be available there to ask questions of all our fantastic speakers that we've got lined up this morning. We've got our international speakers and we've got our committee chairs again, once again, joining us to hear from you out there in the sector. So I want to just a little bit about ACIITC for those of you who are just joining us for this forum. Obviously the National Home Care Group and the CIO Forum are incorporated. Today's forum is part of, as I said, the quarterly national forums hosted by the Aged Care Industry Information Technology Council. Before we go on, I want to acknowledge the traditional owners of the land on which we meet. I won't acknowledge the traditional owners here in Melbourne because we're all across the country listening to today's conference. So please accept this as an acknowledgement of all traditional owners wherever we are in the country, and also a reflection on National Reconciliation Week, and thank the elders for all they do in their communities right across our country. As I said, my name's Aaron Wood. Not only have I had the pleasure of being involved in ITAC for many years, and of course these forums, I'm the Deputy Mayor here at City of Melbourne, and we have quite an involvement in the aged care industry, and certainly have felt the impacts in servicing our aged community through the COVID pandemic. So I'm also having the, I guess, the pleasure of learning a lot through this process as well. For those of you who are in attendance that don't know about the Aged Care Industry Technology Council, they were formed in 2007 by the two industry peak bodies, Aged and Community Services Australia, ACSA, and Leading Aged Services Australia, LASER, with the express intent of providing the industry and the vehicle to consider and debate IT-related opportunities to disseminate the lessons learned from that process in the wide aged and community care industry. We also have people from the disability industry involved in the last forum as well. Just a few housekeeping notes. All microphones, I did say mute your microphones. They've actually been muted by our host here this morning. We are recording today's session. It will be available after the conference. So if you miss anything, don't worry. We'll get that recording out after today's event, and you can watch that till your heart's content. If you wish to ask a question, as I said, use the Q&A panel. We'll get to as many of those questions as we can. Any questions that we miss, we'll pick those up after the forum, and either our expert speakers, our committee chairs, the council, will get those answers back to you after today's event. The session will be available in the coming days on the ACIITC website. During the event, we're going to actually ask some poll questions. So those poll questions will pop up throughout the conference. They'll just pop up, and feel free to participate in those. They are anonymous and will feed into our understanding of the sorts of issues that you're considering. To allow maximum time, I won't be going through each speaker bio. That's going to pop up again in the chat section. So just have a look at that if you're interested in the bios on our speakers. As I said, any technical inquiries, anything that goes wrong, submit a question in the Q&A panel and our technical support will get that sorted out for you. So just a reminder, questions in the Q&A panel during the presentations, raise any technical issues through the Q&A panel, and watch the chat panel for speaker bios and links. So lots going on, as always, when we're on an online conference. We're looking at many different things, but it was a great forum last time. We're expecting a very similar forum today. So to get us underway with our forum today, I'd like to introduce Dr. George Margelis. He's, of course, the chair of the Aged Care Industry Information Technology Council. So we'll give him a big virtual welcome. Welcome today, Dr. George Margelis. Over to you.
Thank you, Aaron. And just confirming everyone can hear me okay?
Sounding loud and clear. Thanks, George.
Excellent. Well, because we did have a few sound issues in the last time. So welcome, colleagues, to the second online consultation by the Aged Care Industry Information Technology Council for 2020. I would like to thank the Department of Health and Ageing for their support, which enables us to run these events. First of all, I'd like to start off by thanking the frontline workers in aged care in Australia. It has been a very hard start to 2020, but our frontline has responded amazingly. Over the last few weeks, I've had many discussions with international colleagues. One thing that does stand out is how well, compared to the rest of the world, Australian aged care has responded to this crisis. This is reflected when we compare our results. As I spoke to my colleagues around the world, I heard stories of widespread infection and amazingly high mortality rates in aged care facilities around the world. Whilst we have had our share of incidents here, it really has been levels of magnitude lower than other countries. And most of the credit for that belongs to our frontline workers. So thank you again for your efforts. Rahm Emanuel, President Obama's chief of staff, is quoted as saying, "Never let a serious crisis go to waste." Well, I think we can all agree that we've definitely had a serious crisis. So now is our opportunity to make sure that doesn't go to waste. As we reflect over the last 3 months, the topic of today's forum of forced innovation and our response to it is especially important. I recently attended an online forum with the Minister for Health, the Honourable Greg Hunt. He said the Australian healthcare sector has delivered 10 years worth of transformation in the last 10 weeks. Where we are now with the use of technology in healthcare was predicted to occur in 2030, and yet the sector has responded to it amazingly. This shows that the sector is capable of change when the right drivers are in place. Our challenge now is to evaluate, improve, and embed that transformation and develop a system that can continue that transformation without the need for a deathly crisis to drive it. Alan Kay, a famous American computer scientist, said, "The best way to predict the future is to create it." Well, we have that opportunity now in aged care, and we need to seize it. As we go forward, we need to collaborate and communicate to develop a plan for digitally enabled aged care in Australia. An important step is currently underway with the CARE-IT project to benchmark the current technological capability of the sector. That includes our online survey of the industry and our vendor partners to help us better understand the capabilities and the challenges faced by the sector. If you have not had a chance to complete the survey, I ask you to please go to our website and do so. It is very comprehensive. It probably feels a bit long, but we really need to know what's happening in the sector. I know we're all very busy now, but I really ask you to make the effort to go to the website and answer the survey. This is a unique opportunity to ride this wave of forced innovation to deliver real change to our sector. It is our opportunity to create the future of aged care in this country. We plan to have further consultations soon to help develop a strategy for a digitally enabled aged care in Australia. This is a journey that we are on together. We have great partners, including the Digital Health CRC, LASA and ACSA, and some very exciting new ones on the horizon. I hope you can join us on our journey. Thank you.
Thanks very much, George. And I'll just encourage everyone at the moment in the chat function, you've got the address there for the vendor survey. George, we weren't going to go to questions, but just an important one. How has the responses on the survey been to date? Do you have that to hand? Are we getting a good response? Do we need to get more responders in there?
We are getting a good response, but we do need more. The more data we have, the more valuable the reflections we'll have on that data. So the more people who can respond to the survey, I know it is long, it is tedious. I know we're all very busy coming to the end of financial year, but that information will drive the agenda going forward for the next few years. And it's really an opportunity to do so. So I know it'll take a bit of time. Make yourself a cup of coffee, sit down, make yourself comfortable, pop up onto the website and answer the survey, and the benefits ensuing from that will be great.
Thanks, George. I really appreciate it. And I can't stress this enough. All my dealings, again, with the council, the committee chairs, is that they want to hear from you, the sector. They're only as good as the information that goes into it from you. So please get online and as George said, grab a couple of cuppas if you need to, a couple of coffees or tea, whatever your poison is, and go and complete that vendor survey. So that's in the chat section there. With the link. The other really important one is the technology roadmap. So again, that link is in the chat function. So please, if you haven't checked out that roadmap, please do. It really does set out the future for the industry, and we need, again, your involvement in that. So thanks again to Dr. George Margellis for welcoming us here today. Very exciting. We're actually going to move into our international presenters now. And the way this session is going to work is that each of our international presenters are pre-recorded, but they'll then join us for a panel at the end of that. So again, please capture your questions in the Q&A function. We'll pick those up as we head to an open live panel for each of our speakers. So I'd like to introduce our first international speaker here this morning, joining us via pre-recorded video, and that is Dr. Malcolm Fisk. And as I said, after we hear from each of our international speakers, we'll actually have an open panel session for you all to pose your questions to. So please use that Q&A function as well. So I'd now like to introduce, let me get this right here. I've got lots of pieces of paper all around the place. Our first speaker is Dr. Malcolm Fisk. So please, over to you, Dr. Malcolm Fisk.
Good morning. I'm delighted to be here to provide you with a perspective from the United Kingdom. And just as a prelude, I want to dedicate this to my uncle Tony Sylvester, who died with COVID-19 a couple of days ago. And that's a reflection of the fact that COVID is touching on quite a lot of people here in the UK at the moment. But today, obviously, we're looking at forced innovation. That forced innovation partly being a result of the COVID-19 crisis and the impact, or the potential impact, on some care models on the workforce and on technologies. Now, I'll just give a little bit of an outline. First of all, you'll see the map there. You know the UK well, and later on I'm going to be drawing on a couple of examples from Cumbria in the north of England and also in Northern Ireland. Just to give us an illustration of what is happening, though of course it's still very early days in the process of services actually changing in a kind of significant way. The UK context generally, of course, there are parallels to Australia around the nature of residential and nursing home provision, around social alarms, technologies and so forth in the home. But I have to say that in current context, I can't really point to much in the way of radical thinking about changed service frameworks. And that's even in the face of the realities that we have at the moment, about the fact that we have such a wide range of new technologies, the fact that we are concerned about the rights and the empowerment of people, the fact that we've got some economic imperatives because of the cost of health services and so forth, that we must rethink the way that we do things or the way we have done things in the past. And of course, we have the COVID-19, the pandemic that has been a real jolt, I think, to all of us. And there's been little change in thinking in the UK either, even though we had this great review that was done in 2019 by Eric Topol, which pointed to all the challenges and opportunities around things like telemedicine and looking at genomics, and looking at apps and mobile devices, all sorts of things in the midst there. So I suppose there's a little bit of disappointment that I have that there hasn't been the kind of radical thinking that we need in order to change things in the UK in some meaningful kinds of ways. So yes, COVID-19 changes everything. My focus today is on telecare and GP services. And the two examples I'm going to point to have both taken immediate action, doing the necessary to protect their staff, to maintain the service to their service users, and also to meet some increased demand. And I suppose I could sum it up by saying they are making do in a difficult position, but at the same time, actually, in some respects, I think they're improving the services that they are provided. Their guidance has been limited, so they clearly are looking to their peers, other services that are doing the same things, how they are responding to the crisis. And there has been some impact of government suggestions or nudging or indeed extra funding, certainly in Scotland, that is available to them to develop their services in particular kinds of ways and to use telehealth more meaningfully. And when I say telehealth, I mean more generally teleconsultations and video consultations, though a lot of the attention is being given to video consultations in this context. And some, as I just mentioned at the bottom of that slide, may indeed have been welcoming the chance to try out video consultations to see how they work. Now, the UK context is not a good one. We've got COVID-19 related deaths exceeding now 37,000, including my uncle, who was one of the 377 reported deaths yesterday. And it's the second highest total in the world. Australia's total is a mere 103 earlier this month. And I view that with, I don't know, almost total incomprehension. You know, how can you guys have got it so right there and we've got it so wrong? 10,000 deaths in UK care homes mid-May, and care workers' deaths, 131. And deaths in care homes still contribute to around 40% of the total deaths, which are running at about 300 a day at the moment. And what we have there is that some care homes in the UK did lock down early in the pandemic, and they did escape the deaths, and full credit to them. Others paid the price with multiple deaths, I'm afraid, including this one, Stanley Park Care Home in Durham, where 12 COVID-19 related deaths by mid-April, and that is typical of a large number of care homes that actually were hit with COVID. And of course, you have the extremes, you have the other ones which have no cases there. Once it's there, the numbers quite clearly increase and spread very rapidly. So some care homes just locked in lockdown early. There is, mind you, a general issue of staff sickness and absenteeism as well, which is a problem for many care homes. And there's been a lack of PPE, personal protective equipment for care home workers. That only having been in place in the last few weeks. That relates to the priority that's been given to the NHS, which I shall mention again in a moment. I think the UK position is a consequence of reckless government inaction, and there will almost certainly be a major inquiry afterwards. They started off with this notion of building herd immunity, the fact that the majority of people needed to be infected in order for people to have resistance and so forth. But that failed to consider the fact that the most vulnerable ones that were going to sacrifice their lives in order to save the remainder. The UK was very slow to act. 12th of March, the World Health Organization said that COVID was a pandemic, and the UK sought, quite rightly, to protect the hospitals, but they did ignore care homes. They allowed discharges to take place from hospitals to care homes. Indeed, they encouraged it in order to keep capacity in the hospitals, but without testing the people who were being discharged. And there was no restrictions, still isn't quite, on tests for people who are coming into the country. And there's this being inadequate supply of PPE and test equipment and so forth. And there's been a crazy kind of rush to get to PPE, and the whole, market system, if you like, the shortcomings of it have come into focus through this, because we're reliant on people sending us equipment from Turkey or from China or wherever it happens to be. And these are commercial organizations that rely on a just-in-time basis, and where you haven't got the stocks, you haven't got the supplies, and they're not even available at these distant countries, and you're not any more manufacturing in your own country, kind of thing. Crazy consequence of our particular system that we work with. Needs a rethink. Right, innovation. That's at the beginning of the title of my presentation, and I'm sorry to say there's not a lot of innovation. I will twist this a little bit later on in the presentation to point to innovative thinking, perhaps, but the technological tools were there for the services to use, whether GP or telecare services. So they quickly use or adopted Skype and Zoom and so forth to do video consultations, and suddenly telehealth has become a new norm within some of those services. And this, of course, is linked with more home working for staff and changes in the support that the services are giving to their service users. And it seems, it's early days though, that many people are perfectly happy to be supported in that kind of way. Maybe the extent of that happiness is increased because of their need to self-isolate, and they don't particularly want to be having direct contact with some of those services, but nevertheless, people seem pretty happy on the whole with being connected to their services in a new kind of way. So the walls around those old service models crumbled in a matter of days. And the question arises, why hadn't it happened before? And this was succinctly put by Trish Greenhalgh in actually a webinar for the or the Digital Health CRC that you had in Australia about a month ago. And she said, clinicians don't have any particular reason to use telehealth, and they thought it a bit weird to be consulting by telephone or video when you could just bring the patient in and look at them as you were taught. That sums it up really with regard certainly to GP services, and also the way that some clinicians or when consultants are very reluctant to change their pattern of working. You can bring the patient in, easy, isn't it? Without too much consideration of what the inconvenience it might be to the patients themselves. Now, so not a lot of innovation. Telecare services were more alert, I think, to the potential for telehealth and for video consultations, but had over the years been fairly cold-shouldered by clinicians, people in the health business, rather than people rather than thinking in terms of health and well-being. And whenever I talk of the term health, I'm not thinking mental health, I'm thinking of the broader picture. And the UK clinicians were able to cite in their defence their resistance to adopting new ways of operating, the indifferent findings of the 2012 whole system demonstrator project, which found that there was no particular cost benefit to telehealth services. And I remember being at a conference in London saying, well, okay, fair enough. Well, now we need to look at whether or not actually it's a better way of doing it. It costs about the same. But actually, there were questions about the methodology, and of course, the technologies that they were working with are much cheaper now. They're more available, including smartphones, apps, and so forth. And so I do believe that the cost equation would come up very much more in favour now of telehealth in favour of video and teleconsultations rather than pulling patients in and so forth in the old-fashioned way. So suddenly, telehealth, at least in the form of televideo consultations, became a new norm, and because doctors, GPs, consultants didn't actually particularly want to touch patients after all. What conditions does telehealth best address? I was actually doing this slide just half an hour or so ago, and it comes from a particular paper that's just come out from Shaw and lots of other people in the Journal of Medical Internet Research. It's a preprint, so it's not quite the final paper, but it gives a list where there's been evidence that tele and video consultations actually do seem to work. Now, they don't work all the time. Obviously, if someone has cancer, then it may well be there's been a personal consultation face-to-face, and many of the other conditions that are listed here, you do need that face-to-face consultation. But for the management of the disease, for the management of the condition, and so forth, after that initial consultation, or perhaps having occasional face-to-face consultation, can be done online. This is what they're suggesting. And I just added a few things here to think about, to help us think about the benefits of telehealth around prompts for medication compliance, around dermatology, skin conditions, and you can use a camera, of course, to help do that. You might have attached to your phone or to your computer. You've got the ability for service users to report on systems, and so therefore you've got possibility of GPs and others doing diagnoses based on the symptoms that are reported. You have the reporting of vital signs, and you have general inquiries, and you could probably add a lot of things to this list. And I think all of us, when we, in a few months' time, are going to be wanting to consider these lists and consider the merits of telehealth, of video, and teleconsultations, and therefore to decide just how much do we need to go back to the old models or not. So over to Northern Ireland. Here we have a telecare service, Radius Connect 24. It's a very well-established service and a well-respected service that actually operates throughout the whole of Ireland. There are 23,000 people online, so it can't be ignored. These are vulnerable people who benefit from a particular kind of service that has evolved in a particular kind of way. Many of them will have medical conditions. Most of them will have medical conditions, and so forth. They are very much in the health arena as opposed to just the social care arena, and many of the users do have peripherals attaching to their care phones, such as fall detectors and other vital sign devices. And this reflects very much the collaboration that this service does have with a number of the local health boards in Northern Ireland. And they have a COVID-19 action plan, which gives us an idea of what they did, what they have done in response to the pandemic. They have, to ensure the appropriate distancing of staff between each other, of course, they've reduced the number of court handling workstations. No longer this big room with, I forget how many it was now, 18 or so people working together. But you have only a limited number of workstations with greater space between them. They've actually split to another set of workstations on another site. But more importantly, they have many, many more staff working from home and actually responding to calls from home. And it does really appear that that will probably carry on after this particular crisis, because there are some advantages to that. They have deployed extra staff from other parts within the organisation to do more morning calls out to people to check on their well-being. More important now because of the risks around COVID-19 and also the concerns that people have at home. They've got extra vulnerability and worries of people who are at home. They provided laptops for their advisor team so they can work from home. More aspects of the work are now done paperless. So they're not shipping papers around the office and things like this, and don't need to do that. And interesting one here around installations and maintenance. They used to have staff going to people's homes to install the devices and the peripherals. Now it's done by courier and with telephone support here. Now, there may be some areas where that means they can't quite do everything they would want to do, but nevertheless, I think a lot can be done in that kind of way. Limiting the number of visits overall so that when visits are taken, they have adequate PPE, and quite naturally they're doing ongoing assessments of the risk to their staff and so forth, and of course to the service users at the same time. So less staff sickness, or less risk of staff sickness, they think. They expect to have reduced staff absences because they're working from home, and greater flexibility as well. So if you need extra staff because of a particular high demand, it's easier to get them in to do a couple of extra hours, stuff like this. And the whole thing subject to further review, including the role for video and teleconsultations. But not all services have the technologies that would enable them to do that. So that might indeed require some extra investment to bring that into play. Cumbria, the north of England, Cumbria Health on Call, very interesting, lovely service, I like this. Not-for-profit primary care out-of-hours service covering most of Cumbria, and oh gosh, an awful lot of GPs involved. I think this is exemplary and maybe pointing to the way that things can be done in other parts of the UK, and especially because of the fact it's not-for-profit, and it's also collaborating very, very well with sector organisations in the area. And they have gotten locations, see here, the vehicles where they do go out there and obviously visit people where necessary in response to particular urgent or necessitous calls. They do video consultations and teleconsultations, and they use the Attend Anywhere platform, which many of you will know is actually an Australian product. And the whole approach to people actually going into this particular platform and consulting with GPs is based on the real doctor surgery. So you get a sense of them coming through the door, being in the waiting room, being called when it's their turn, and being allocated or going to a particular room where they can consult with a particular doctor. So the whole process is very easy to follow and almost natural to follow because people have done it in their local surgery. They are ramping up, or they have been ramping up their service in February. Look at this now, 23 clinicians giving 123 video consultations, taking 30 hours. That's in February, 23, yeah, oh, whatever it is. Anyway, and then go through April and May, and then you've got 316 clinicians, not 23, you've got 316 clinicians, 1,700 consultations, and 574 hours of consultations. It may or may not be significant that the average time of the course has gone up a little bit from 15 minutes to 20 minutes. All of this, of course, will be subject to further evaluation and analysis so that they can plan for the future as the COVID-19 crisis abates. And there's a good training guide there. And if you haven't got time to write this down, then by all means contact me and I'll send you the details so you can look at what they're doing. And this takes you through that stage by stage through the process of the consultation that takes place. So what are the implications of all this? These are my initial thoughts. Yes, good telehealth services can serve people well. How well is not entirely clear, but the dam has burst and it's here to stay. Telehealth is here to stay, but we do need better networks, reaching all parts of our nations. So I think government should be prioritising broadband throughout the country. And this, of course, should, if we deliver or provide the services in the correct kind of way, should help to reduce health inequalities. So there's the danger, of course, with any kind of digital service that we could be making any digital divide even worse. Oh, one interesting point, I mean, some of the telehealth services have been restricted to rural areas. Now, rurality isn't the issue at all. It can be anybody, everywhere, because of the issue of COVID and the need for people to self-isolate. And smartphones are, of course, increasingly available to all of us at relatively low cost. Hugely important. We have connectivity when we're on the move, when we're in work, when we're at work. Great stuff. And it also means, of course, that we're not just talking about older people, we're talking about all of us wanting to manage our health in new kinds of ways. Oh, yes, and there is an imperative, and I must have said this 100 times or more. We do need greater interoperability, and I'll come on to a point later which is suggesting that this is something we should emphasize in the way that we procure, buy, talk about, plan and our services. And here, I said it's ethically and morally inappropriate if services are commissioned or procured in a way that allows vendor lock-in because of the lack of interoperability. So we must use the COVID-19 crisis as an opportunity to rethink our perspective on health and social care in that kind of context, but also in breaking down, if you like, the barriers sometimes that there are between health and social care workers, not thinking about them as in two entirely separate domains. Now, there's also the need for us to encourage people to become more health literate, for all of us to become more health literate and to take more responsibility for our behaviours and lifestyles. And that will equip us to become much better, more equal partners in our healthcare, and with less need to call on GP or other services. Obviously, we need to for certain things. That's absolutely right. The GPs, the consultants have got all kinds of expertise that we haven't got. But nevertheless, the basic point is a sound one. Now, this is an area I need to do more work on because I don't, even though I'm saying this, I'm not sure I fully understand the context. Electronic health records, and even personal health records, which are supposed to be more responsive to our needs and allow us as patients more access. But everyone seems to be planning services in a way that feed into the electronic health record. Now, that's not to say that it's not important, of course it is, but really I would like to see us having personal health and well-being records, and then with the EHR being an offshoot of that, rather than us kind of feeding into something that serves a purely clinical agenda. The well-being agenda is just as important there. So maybe we need just a bit of a change of thinking there. And we have, let's face it, when we're talking about health records and things like this, especially unified health records, we spent an awful lot of money, UK and Australia, on systems that haven't worked. And maybe we should be looking at things in a different way. And linked with that is, as we are demolishing some of the boundaries between health and social care, should we be having a new kind of practice worker, health and well-being practitioners skilled in care, knowledgeable around assistive and communications technologies with the status of nurse practitioners and paid accordingly. Of course, social care workers should be in that particular mix there. So better digital networks, these are the innovations we need. Better digital networks, reaching and engaging with the poorest and the most marginalized, and telehealth services to embrace health and to get digital. So many services still work on an analog basis in the UK. We want full interoperability of the technologies with open protocols and with the clinical records and the phone in my pocket, and for telecare peripherals and care phones. We want new platforms that aren't narrowly based on the needs of clinicians, and they're about all of us. And we need proper recognition to care workers, telecare workers, for their manifest skills and abilities, and a pathway or pathways for them to become part of a new raft of health and well-being practitioners. All kinds of implications for recruitment, training, and career development, of course. So, two take-home messages. This is a new beginning for telehealth, and these are messages to the aged care sector, and they are of wider relevance. They're aimed at, first of all those who set the policy frameworks, who specify and procure the technologies or commission the services, to make sure that they are demanding what is truly needed, not just for service continuity, but that's of course important, to respond more flexibly to needs, hopes and choices of people, patients, etc. Us. Now that's a very general point, but I think that you agree with it. And for all those involved in the aged care sector who need to push for greater recognition of care workers, I think many of you are doing that, and for telecare workers, but also to support moves to that new kind of roles to which care workers can aspire, and helping to make a nonsense of the hitherto held to boundary between those old domains of health and social care. And finally, just an end note to mention that myself and Sabrina Pearson and Livingston have written an article which has just been accepted and will be out very shortly in the Journal of Medical Internet Research. It's looking at telehealth in the context of COVID-19, changing perspectives in Australia, the United Kingdom, and United States. Now, it's a good read, I think, and provides a look at the respective responses of the three countries in the pandemic in the 2 weeks from the 2nd of March. And I very much hope that we can carry on with the collaboration and doing more work on this, including some specific attention to care homes and the implications for the way that they operate. So many thanks. Diolch yn fawr.
Excellent. Great to hear from Dr. Malcolm Fisk, and obviously a very important topic for the sector, given the federal government announcements quite early in the piece there around telehealth in relation to COVID. We've seen that step change here in our country that Malcolm is speaking of, and we've had a number of questions flow in for Malcolm that we'll pick up in our panel session just after this as well. Interesting to hear about that new normal and that it's taken really a crisis to take us in that step change that many of you I know out there have been pushing for quite some time in terms of the recognition of telehealth and the important role that it can play in the health and also social sectors. So we'll pick up some of those questions as we come to our panel. So as you can see, we're taking a bit of a trip around the world here. We started off there with the UK. We're going to hear from our next speaker in just a moment about the European experience. So we'll welcome Miss Adriana Shikaru, who's going to talk about that European experience on COVID-19 and what is the workforce focused outcomes of that. So please, can we give a big virtual welcome to Miss Adriana Shikaru.
First of all, thank you for the invitation, and I look forward for the inputs from every participant at the event. A few words about me. My name is Adriana Ciacâru. I am from Romania, and I am the president of the Youth Commission in the largest trade union in my country and vice president within the European Trade Union Confederation, which is the largest organization and represents over 45 million of workers all across Europe. This is all voluntary activity, and in my professional life, I work as a civil servant in the field of care system for children, adults with disability, and aged person. I am also an expert for this European Confederation in ISO Technical Committee 3 and 4, Aging Society, Working Group 1, Aging Workforce, where I had the pleasure to meet Anne Livingston, an expert in aged care system and a real professional when it comes to work she is doing in this field. Now, going to the presentation, I chose this topic because it represents a subject already tackled at different levels even before the pandemic. Also because our own experiences are a source of inspiration. So the pandemic has transformed the way me and most of my colleagues do our jobs. For example, until now, working from home was impossible to be approved by my boss, the general direction. Well, now 90% of my work is telework, working from home. The topic chosen for today, digitalization in time of pandemic, I completed it with a question. Is digitalization an option, a possibility, or a must? This is something I am kindly ask you to reflect upon and to ask a question or to share your experiences. This presentation has a few aims or discussion points, such as which is the impact of the pandemic in different sectors, domains, how were the workers, the individuals affected by it, And what about aged care system workers and residents? As you may see, there are a few questions to which I will try to answer and to provide you some examples from my own experience. Now the first slide. Regarding the first topic, there are a series of differences, but also similarities between the impact on sectors, domain, or on different types of worker working contracts. The burden is felt by all sector and domain, but in different ways. For example, the public sector was considered as an expenditure or a cost in different countries instead of an investment. In this field, in order to help citizens and offer their services, there was a need to direct interaction between people and the civil servant. For example, to complete or to submit different papers, you needed to talk with a civil servant. During the state of emergency, more and more governments have forbidden this direct interaction, and most of the public services moved to online services where possible. This is the case also of other private companies as well, such as banking system, IT industry, and others. The differences between this sector and domains is mainly based on the specificity of the activities carried on by a certain company or public institution. And here I'm going to offer you two examples. Digitalization has less impacted domain as healthcare or social assistance, where the main activity is focused on helping, talking, or taking care about people where you need physical interaction. On the other hand, in the private sector, like agriculture industry or construction field, where digitalization cannot be replaced by the work done by people, workers have lost their job or their income was affected. Digitalization also impacted workers in different ways depending on their type of working contract. For example, people with non-standard forms of employment, such as people who are working on online platforms, remote workers, are less impacted by the digitalization during the pandemic, though the working contract they have might make the difference. Although their job is not changing because they still work from a computer, the access to social security, sick leave, and other rights can be affected. These differences are seen between people doing undeclared work versus the ones that have a classic working contract. But what about the workers, the individuals? This pandemic has obvious effects at industry level, national level, company level, but most affected are the individuals of all ages. This is an unbalanced pressure on different categories of workers, and here we can relate to the aspect mentioned before, depending on the domain where the workers have a job, how much the pandemic changed the tasks from work, etc. Also, during the pandemic, workers are confronting with a lack of resources, internal procedures, elements which are increasing the level of stress or sometimes are determining the impossibility to fulfill the requirements for more. For sure, digitalization and working from home has an impact also on the life-work balance. Let's consider here the case of a young family living in an apartment, having one or more children and no space available for an office. How to manage the family responsibility with the new working condition and still keep your job. During the pandemic, I have also heard the case of people who were made redundant because the tasks from their job were automated. We are talking here about Industry 4.0, defined as a name for the current trend of automation and data exchange in manufacturing technologies, including cyber physical system, the Internet of Things, cloud computing, and cognitive computing, and creating the smart factory. Negative effects linked to the digitalization. Most of them are obvious, and this will have to be analyzed in order to overcome them and to prepare workers for the next period and things to come. So here we can mention job losses, stress and frustration, exposure to risks associated with the pandemic, lower income, and high competition and discrimination. Also, there are some positive effects, because as I mentioned, there is a difference between the public and the private sector. And I think the majority of people from the European countries have seen a de-bureaucratization of certain processes, more investment in technical skills, the possibility of reskilling and upskilling during this pandemic. There is more communication because we are forced to use different tools to communicate. And one positive effect is that the pandemic overcome the reticence for new technologies. And now going to a topic that is linked to the event and brings a perspective about the aged care system. As I was mentioning at the beginning, I am a volunteer in the trade union movement, so my activity is based in the public care system, where I have a focus on quality management of the social services. So I see the challenges in the field, especially in this period, because an important factor we have to take into consideration is the vulnerability of the residents, the risk associated with the pandemic, and their exposure to those risks. To give you an example, to better understand the diversity of laws in different countries during the lockdown, I will tell you a few words about what happened in my country. So, measures during the lockdown. The government has released an emergency ordinance which basically blocked the employees at their workplace for 14 days. According to the legal provision mentioned there, workers were forced to spend 24 hours per day for 14 days in the care centers where they work. Of course, this overnight change has brought reactions, especially from our side as trade unionists, the voice of the workers, but unfortunately with no effects at the government level. There were some challenges during this 14 days period, such as fast adaptation. Being away from the families was really difficult for most of the workers, and this led to a high level of stress and uncertainty for their future. But also, there are positive effects of this experience, and one of them was that there were obvious improved relation between the employees and the residents, because the workers were there all the time having different and diverse activities. Also, from the point of view of digitalization, they were forced to quickly adapt and to add technologies in their work and at their workplace. Their efforts and sacrifice in the end was rewarded thanks to our efforts as trade unionists, so they will receive a bonus for these hard times and for their sacrifice. And as I was saying, it was a challenging period for all. And in this regard, I believe we should consider some priorities when it ends and even before. We have to think about some measures to respond to the challenges this pandemic brought, and regarding digitalization, but not only. As you may know, we have an agenda set by the United Nations, Agenda 2030, with 70 Sustainable Development Goals, with a very important Sustainable Development Goals number 8, decent work and economic growth. Regarding education and the concept of lifelong learning, will we have the possibility to choose? Will we leave this to the employer hand, or we will intervene? Where are we now? Are we adapting fast enough to the digitalization and all the processes? Well, I think we should focus on promoting digitalization among workers of all ages and from all sectors. Of course, it has to be an adapted process to meet the requirements of each domain and each field. Another thing is cybersecurity, because we are all working from home, we are using personal computer in some cases, personal internet connection, and we are talking here about security, data protection, and this is something we will have to consider as being a very important part in our process of digital literacy and security. Well, how can workers be protected from this type of situation? Well, are the residents of aged care facilities protected enough? This is still place for discussions, debate, and thoughts on the topic. Hope you find the information provided useful, and I am keen to hear your feedback. Thank you.
Excellent. Very good to hear from Ms. Adriana Shikaru about impacts on the workforce. So you can see in terms of this session with our international presenters, we started off with Dr. Malcolm Fisk looking at technology, Adriana looking at the workforce impacts, and we're going to move to Professor Greg Alexander, who's going to actually look at the care setting. So as you can see, all these are joining up in terms of the issues across the board and the impacts that COVID has seen. Again, we've got a number of questions for Adriana that we'll pick up in our panel session. So we'll move now to Professor Greg Alexander, who is from the US. So we've heard from the UK, from Europe, and also from the US lastly. And as I said, this is about looking at the care setting. So please keep putting your Q&As in that Q&A panel, and we'll pick those up with our panel very shortly. But please, can you give a big virtual welcome to Professor Greg Alexander?
Good morning. My name is Greg Alexander. Thank you for that introduction. I'm going to talk to you a little bit about the USA experience with COVID-19 today, specifically in a care setting that's focused on long-term care. The title of this presentation is Telemedicine and Electronic Personal Protection Equipment, or ePPE, in nursing homes. This is a measure of readiness of telemedicine in nursing homes in the US. I have two disclosures to report, including Technolytics LLC, a limited liability company that I'm the owner and founder of, and Agency for Healthcare Research and Quality, which is a national federal agency that funds research here in the United States. I'm a National Advisory Council member on that group. This illustration provides a glimpse of the pandemic's world impact. In the US alone, which is in the upper left-hand corner, as of May 27th, 2020, this past week, 1.6 million cases and nearly 100,000 deaths were reported, and I believe we have reached the 100,000 deaths just over the weekend. And this number is still rising in our country as well as others shown here. New reported cases by day in the USA are shown in this illustration. Cases began in the US in mid-March 2020 and rapidly rose, peaking around the first week of April, then slowly declining. Still, new cases are being reported. However, the spread of the disease does appear to be declining and on the downslope. Long-term care settings are hotspots for this illness. 11% of all cases in the US are in long-term care. Over a third of all deaths in long-term care occur as a result of COVID. Positive cases, or about 153,000, have been found in nearly 50% of all long-term care facilities across the US. We have over 16,500 facilities in the US. Total deaths are around 28,100 for residents and workers in long-term care facilities. Some of the greatest concerns by nursing home administrators in long-term care facilities during the pandemic have been lack of supplies, staff shortages, resident health and safety, and the availability of personal protective equipment, PPE, including N95 masks and respirators to protect staff and residents living in the communities. To protect workers, residents, and community, telemedicine opportunities were expanded in every state in the United States. Telemedicine is defined under this opportunity as the ability to exchange medical information from one site to another through electronic communication to improve patients' health. Here's a brief timeline of events that led up to the telehealth expansion, which started in March and ended in April, just over a month ago. And the use of telehealth and the encouragement of telehealth through a telemedicine toolkit was released by the Centers for Medicare and Medicaid. The Centers for Medicare and Medicaid is a insurance, an organization that provides insurance for older people after they retire, and it does pay for some long-term care services as well as just other illnesses as people age. Three main types of virtual visits were encouraged using telemedicine through this roadmap that the Centers for Medicare and Medicaid provided. This included use of phones, tablets, FaceTime, collaboration platforms, any type of technology that would allow a home to connect to a provider to get visits done. This included telehealth, virtual check-ins, and e-visits. And by telehealth, I mean virtual evaluations and communications between providers and patients. Essentially, these are short communication exchanges using technology of any sort. There were billing codes established for the telemedicine activities shown here in the center of this table, and rules distinguished between new and established patients among these different types of visits. Telemedicine tools, including technology, have been conceptualized by Tour and others in a 2020 article in the Journal of the American Medical Informatics Association as a form of electronic personal protective equipment, or EPPE, to protect people living and working in healthcare settings like long-term care. EPPE requires technology to be used with medical screenings and evaluations to prevent the spread of the disease. So you can see here, this provider is looking at a screen. He's doing an evaluation of a patient. He can see the patient. He can see the MRI that is shown on the screen that relates to that patient, and he's able to actually document and do a virtual visit utilizing telemedicine. And this was being encouraged in any format that could be used in nursing homes to care for people to prevent the spread of COVID in our country. My team and I have been funded by the Agency for Healthcare Research and Quality, a U.S. federal agency I mentioned before, to explore technology use in nursing homes since around 2017. In the second national study that we're currently conducting, we began a national survey in June of 2019. When the telemedicine expansion rule was put into place around March or April of 2020, we began looking at our sample of nursing homes that completed surveys in the national study. There were approximately 522 at that time, to explore EPPE use as a measure of telemedicine implementation or telemedicine readiness. The survey times were from June 3rd to 2019 to April 7th, 2020. We had 2 research questions we wanted to answer, which are shown here. And to answer these research questions, we selected 6 questions from our survey, also shown in this box, about telemedicine. And we created an EPPE score based on the responses. The responses for each survey question ranged from 0 to 7, 0 indicating telemedicine not used at all in the facility, 7 indicated telemedicine used very much. The EPPE score total for a facility ranges from 0 to 42. So for example, on the 6 questions shown in the box, if a facility answered 7 on each question, 7 times 6 would be 42. If another facility answered 0 for each question, they would receive a score of 0, hence the range 0 to 42. In the table, you'll see the responses to each question based on a yes versus no response. A no response would indicate that a home had a 0 on their survey response. For example, you see that 73% of the nursing homes reporting did not use telemedicine for evaluation of residents and pre-transfer arrangements. However, over 51% in question 6 reported capabilities for remote order entry for medications from locations outside the nursing home. For example, the MD had access from his home or her home, access from the office or clinic, and could directly input information into the medication management system, which is a form of telemedicine in itself. This slide shows the total EPPE mean by our nursing home sample's organizational characteristics for bed size, ownership, and location. The nursing home sample, like I said, which was 522 facilities, was reflective of the population according to location, but not bed size or ownership. So the population that had not participated in our survey, around 14,000 facilities that were remaining, this sample is, we were looking to make sure it was characteristic for the generalizability of our findings. We used a statistical method called post-stratification, to reweight our scores to adjust for differences. And like I said, there were differences. They were similar in according to location, but not bed size or ownership. So we had to adjust for those differences. We found total EPPE was significantly associated with nursing home bed size after we reweighted the scores. A larger nursing home, greater than 120 beds, was expected to have a total EPPE of 6.06 points higher than a small, less than 60 bed nursing home. A medium nursing home, 60 to 120 beds, was expected to have 5.25 higher total EPPE score than a smaller. So basically, smaller homes were statistically different in their scores from large and medium-sized bed homes. Nursing homes in our study had the full range of total EPPE scores ranging from 0 to 42, with a total mean of 14.4. Among this sample of 522 homes, 96 homes had EPPE of 0, and 15 nursing homes had a maximum EPPE score of 42. This table shows results of our examination of relationships between EPPE score and organizational characteristics. There were significant relationships according to the nursing home bed size and location for electronic reporting of laboratory results to the nursing home. For example, the odds of a nursing home located in a metropolitan area having electronic reporting of lab results was 3.23 times the odds of a rural home having the capability for electronic reporting of lab results. Bed size was also significant in electronic reporting of lab results. The odds of a large nursing home having the capacity for electronic reporting of labs was 4.7 times the odds of a small nursing home. The odds of a medium nursing home having the capacity for electronic reporting of labs is 2.34 times the odds of a small. So large and medium nursing homes had much higher odds of using telemedicine than did small nursing homes. Similar results are shown for electronic transmission and reception of laboratory results. Larger and medium-sized facilities were just more than 2 times more likely to have remote order entry compared to small facilities. In conclusion, U.S. nursing homes in this sample have a wide range of EPPE use or telemedicine readiness, with 18% reporting no EPPE use, only 3% with maximum telemedicine or EPPE use, and 79% having some sort of partial implementation. Overall, mean EPPE use for the sample was low. There's room for improvement. There are opportunities to target telemedicine interventions and EPPE use in nursing homes based on their defining characteristics. I want to thank the committee for putting this together and for inviting me to participate. It's a great honor to present to you some of the work that we've been doing. And I want to leave you with my contact information and a big thank you. Thank you so much.
Thanks very much to Professor Greg Alexander. And what we're going to do now is we're going to jump to our panel session. So we'll stop sharing the screen so we can bring everyone up on screen. And I've got a number of questions which I'll go to quite quickly. So we can bring everyone up on screen there after we stop sharing the presentation, and we'll go straight into our questions. I just want to check that I've got all of our speakers there. I can see Greg, I can see Adriana there, and we will jump straight into some of those questions now. Adriana, just a question for you, which is you know, it's a sensitive question, but it's a question that we need to ask. It's come from one of our participants who talks about understanding the need to protect workers from someone in their care that has COVID. But then how do you, I think the crux of the question is, balance up the rights of the customer, the client, the person requiring care, particularly if they have dementia. So, you know, in our people in elderly populations, you know, dementia is an issue, and they may not actually respond well to digital communication or online communication. In fact, it may cause, you know, greater anxiety. So did you get any insights into how to balance up protecting the workforce, but also still being able to deliver on the rights of those in care?
Yes, thank you, Aaron. Well, this pandemic has brought a lot of challenges, as we may see, and we as trade union at different levels within my local trade union, at the national level and also at European level, we have different activities and actions under development. And to express my opinion regarding the specific example you gave, is very important to have enough information, first of all, about your rights. That means you have to identify a provider for this information. And if you ask me, I would go to my trade union to ask if I have enough coverage for this period. That means some legal rights about sick leave, if it's the case, the rights to disconnect, because what I have noticed in this period is the fact that there isn't a balance between work and life, as I was mentioning, and also there is a thin line between what I have to do within my working hours, and sometimes the employer asks for more. So this right of time to disconnect is an important initiative we have at European level, and it's promoted and also implemented in certain countries as France.
It's interesting because, and I'm sure you're seeing this too, Adriana, in your look at how COVID's impacting the workforce, that, you know, some workers are reporting good outcomes because they're well set up and they've got the means, and their job categorisation is such that this is actually assisting them. They might have less commute time, so that's a good thing for them. But that sort of intrusion into home life is one that I'm hearing a lot of. Dr. Malcolm Fisk, let me come to you, because you did answer this question in the chat function, but I think it's important. We see the numbers in the UK, in the US, you know, in parts of Europe, and in Australia, it is very difficult for us to fathom. But there was a question around saying, do you think the numbers in terms of mortality rates relating to COVID are inflated? You did answer that in the chat function, but I want to give you the chance to actually answer that, so all participants can hear about that.
Yes, indeed. I think, first of all, obviously I've had a few minutes more to think about this and hopefully fine-tune my response. I suppose the fact of the matter is that most nursing and residential care homes do have quite a high proportion of people who have one or other of the dementias. So we are talking about maybe half or more in that kind of situation. I mean, the question raised by Lynetta was
whether or not might be additional distress, for instance, for people with dementia, and clearly highlighting the fact that communication with people with dementia is hugely important. And many care staff, by the way, as we all know, very often have developed tremendously good skills at relating to people with dementia and have some good interpersonal relationships there, which we would want to encourage and build on. Now, if someone appears clearly with PPE and with shields and with masks and things like this, obviously there is the potential for that being distressing to someone with dementia, and it means that there's an added premium, I think, on the need for that communication. But it does, the clothing and what have you, and the gloves does enable touching, of course, to take place and reassurance to be given. And I think it's just adding the premium to that. Whether actually older people with dementia are actually more distressed by all of this, I don't know. And I genuinely haven't seen any evidence of any research that's actually touched on that. No one's mentioning it to my knowledge.
And Malcolm, can I just get you again just to highlight in terms of the numbers, the mortality rates that you're seeing? You did comment on those in the chat function. You believe that they're much higher than what is being reported?
They are. If you look at the excess deaths, now some of those excess deaths are because one of the unfortunate consequences of COVID and people self-isolating is that people aren't reporting if they have different medical conditions, nothing to do with COVID, and so they're not seeking medical help for those other conditions. So some of the extra rate of mortality is down to that. But there's nevertheless still underreporting because of the lack of testing. And the UK is far behind the curve on this, they really are. I mean, if you look at obviously the United States is streets ahead in terms of numbers, but if you look at the proportion in relation to populations, I'm afraid the UK does very badly. There are some smaller countries that do very badly as well. So we don't necessarily, we shouldn't just look at the numbers, we should look at the impact on different countries in proportion to their population. What we do have, and we certainly share, as Greg's pointed out, with the US, is care homes as hotspots. And it'd be interesting to hear from him if there was this terrible situation that we had in the UK where the NHS was prioritised to keep the hospitals safe and not be overloaded by what they thought was going to be some kind of tidal wave of people with COVID. But what they effectively did was caused a situation where older people had to die for the sake of saving the NHS and our hospitals and making sure there was sufficient vacancy rates in hospitals to cope with the numbers of COVID patients.
Malcolm, let me, you've spoken about sort of the new norm and the breaking of the dam, and we've certainly seen a huge step change in telehealth here in Australia, and the federal government stepping in to change the funding arrangements as well. Mike online has just asked a question, and I might get George Margellis to jump in on this one as well. But a recent Australian survey indicated high consumer satisfaction for telehealth during the COVID crisis, but then indicating that most won't continue with this after the crisis. Why is this, Malcolm, from your perspective? And then George, if we can get you to come in from an Australian perspective after that. Malcolm?
Well, you did just say there that most won't continue to use it in the future. Well, actually, it's going to be one of the choices available to them. They will be more aware how to relate to and use the technologies. So the fact that a proportion will means that things are fundamentally changing. And the doctor surgery, the clinicians and so forth will be making sure that telehealth is amongst those offerings. And because they are very often overloaded and have long waiting lists and things like that, they will be encouraging people to use the technologies. The technologies will become easier as well. There's no doubt about it. And so the clunky nature of some of the links that we have and the dangers of breakdowns during the course of telehealth consultations will diminish as well. So yes, I think you'll get more and more people staying with telehealth, even though George's survey shows that a lot of them would go back to the old ways.
So George, can I get you to come in just from an Australian perspective? I think Malcolm's, clearly saying that the change is on. There is a transition happening. It's not going to happen overnight. There's been a huge step change, and you'll get some drift back to, the the way I've always done it. But from an Australian perspective, what do you think we'll see here?
Well, yeah, I mean, we often talk about the 2 steps forward, 1 step back. In the case of telehealth in Australia, it was like 50 steps forward, so there will be some stepping back. 2 issues arise. One, that one of the recent survey of GPs have shown that the bulk of telehealth consults in Australia have been done purely by telephone, so basically voice interaction only. And that's a limiting factor because that is good for very small issues, things like repeat prescriptions, like paperwork, ongoing care of people who already have a strong relationship with the GP. But when it comes to new conditions or new issues, it's really hard to manage. And in particular, in patients in aged care facilities where a physical assessment, eyeballing the patient and having an understanding of what their status is really important. That hasn't really been able to be delivered by the telephone system. So we've had a telehealth light scenario. We haven't had a full telehealth scenario. Part of that because we had to do this very quickly. I mean, we've been looking at things like remote patient monitoring and use of high definition video conferencing for years. But when the push came to shove, those systems weren't readily available for GPs. They had to deliver services in very short timeframes, and they reverted to the lowest common denominator, which was the phone. As we develop capability, I think people will see the benefits of the more capable services and also the more capable practitioners who utilize those services more effectively to deliver care in a different model. The standard model we have at the moment isn't doesn't take full advantage of telehealth. If we change the models of care going forward, and I was on a webinar just last night with the Australian Digital Health Agency looking at the use of digital health in residential aged care facilities. Things like management of medications through a end-to-end supply chain using telehealth solutions make a big difference. So we've taken a lot of steps forward. Like the Minister said, we've gone 10 years transformation in 10 weeks. We're going to have to reset the normal, evaluate what's worked, what hasn't worked, embed the good stuff, take out the bad stuff. And there has been some issues of people abusing the system. And I won't go into detail, but some people have sort of been billing for services through telehealth that they probably shouldn't have. But I'm positive we will see a step change. How big a step change, that's going to be very dependent on us as the industry.
Thanks, George. And look, again, it's one of those things where the change is on, whether we sort of embrace it or not. And I just want to highlight again the technology roadmap, the work of the council, the vendor survey, all of these sorts of things, as George has mentioned there about sort of keeping the good things and taking out the bad things. That's why we have the council. That's why we're asking for your input into things like the roadmap. So please do. Greg, I want to come to you. This is a question about how hard it is to collect the data for your research, and in a perfect world, what would the model for data collection look like? And then just another question, which you may or may not be able to comment on, but the COVID-19 app, which has been widely downloaded in Australia, what's your views on that for research purposes, if you're aware of the COVID-19 app?
Well, there are lots of different types of data sources that are out there. You saw in my presentation a couple of different data sources, one from the New York Times, one from Johns Hopkins University. Every country sort of has their own take on tracking data for COVID. Contactless and contact data is becoming extremely important, and my take on data and utilizing it in research is really thinking about where that data come from, how it's collected. I think Malcolm sort of hinted about that when you asked the question about the accuracy of reporting illness, and COVID related deaths, because and the incidence of COVID and how it's spread, whether it's through community contact or whether it's another way. And there's some, at least in the United States, there's been some inconsistencies in that kind of reporting until we've actually gotten to the point where we have massive testing stations set up all across the country with hundreds of people being tested, and that actually gives you a better feel for where the hotspots are and where some of these interventions may become more effective. And so, you know, I think you have to really look at those sources very carefully to draw your conclusions.
The COVID-19 app, Greg, have you had much interaction or experience with that? And in terms, no?
No, I have not with the Australian COVID-19 app.
Well, I think that's one that's going to be an ongoing conversation. It's going to be a very rich data source, but just how it's utilised, I think, is certainly going to be a conversation. We're going to move very shortly into our next panel and presenters, but I just want to, before we leave that, pick up on a question, and I want to thank again our panellists as well, Adriana, to you, Greg, and also to you, Malcolm, for joining us. There's just been some questions here which I know some of our committee members and our next session will pick up on, you know, what can be done to help small and regional rural-based aged care providers to better use technologies in their services, and they're concerned that this this crisis might be used as another reason to transition aged care towards larger providers. So let's try and pick that one up in our next session. But please, again, I think we could go on forever on this panel. I know I could. I've got so many more questions for you that have come from the floor, but we'll pick those up after the session. So again, thank you to Dr. Malcolm Fisk, Professor Greg Alexander, and Ms. Adriana Shikaru. Thank you very much for your presentations today. So we're going to move, as I said, on to our next session, and this is about future agendas for the sector. So future agendas for innovation and technologies in aged and community care. I'm just going to introduce Miss Anne Livingston, who needs no introduction really. She'll introduce Dr. Kate Barnett, OAM, and Mr. Gavin Tomlins, and we'll flow through our next sessions. We'll also have some poll questions in this next session as well. So over to you, Anne.
Thanks, Aaron. Thanks everyone for attending today. My mission in a couple of minutes is to give you a quick overview of where we are to date with the CARE-IT, or the Care Innovation and Technology Research Project. We gave a full update on the project at our last national forum, and we've been travelling around virtually around the countryside, doing consultations, attending network meetings, and providing some both topic specific consultations on issues, as well as looking particularly on the care settings that are involved, both community care and residential care. We pulled from this a range of consultative groups, and I'd like to acknowledge the expert reference group for the project. Thank you, Professor Greg Alexander, for joining this group. Dr. Claire Mason, from Data 61 CSIRO, a senior data scientist who's doing some fabulous work with us around analysing the data. Also joining that group is Rod Young, and many of you will know, no doubt, Rod from his founding membership of the Australian Aged Care Industry Technology Council, and also the work that he's done for over 16 years now in hosting ACIITC. The group is chaired by Dr. George Mangelis, and they've been critical to the work of this group. We've also set up a number of other consultative groups. One is the National Reporting and Business Systems Expert Group, and I thank those members for their input. We are going through the numerous range of data sets and reporting that are required to governments both national and state, and revolving around the issue of delivery of aged care and community care services. We've also put in place a vendor co-design group, and I'd like to acknowledge those vendors who have come and have supported the work that we're doing. And we've had an industry co-design group, and I haven't got them in front of the screen here, but I did acknowledge them individually in the last presentation. it's been a great assistance to us having their support and their ability to canvass their comments on the design, both of our study but also of the survey. So where we're at now is doing a range of case studies. So thanks everyone for those people who've come forward with case studies, and also those who've been providing research. We have analysed all the academic research, but it's the grey literature that we're really keen to explore. So if you actually have some research going on that may not be published yet within your organisations, within specific areas of interest, we'd love to hear from you, even if it's early research. So we thank those researchers who have come forward with their great ideas and have been able to share with us their early stage research. And we've also made a number of contacts with key informants around the world. So I've had a collaboration of over hundreds of internationally recognised experts in this area, both in research but in practice. So where we're going now is we're in the final stages of the survey. We've had hundreds reply to both the vendor survey and the industry survey. So we call on you to add to that number of survey recipients. And we are drilling down on really what the evidence is telling us about effective and impactful technology, but also innovation in practice. So I'd just like to acknowledge the vendor involvement. This has been a very important part of the project. And we really appreciate the support that we've got from individual vendors. Many of those are online today. And also from the vendor peaks who have been supportive in helping us put together the survey, comment on our research areas, and also to provide input and a promotion of the survey. But what we have found, and what's been a bit overwhelming for us, is that the range of new vendors in this space, and by vendors I'm also including in there startups and new technology developments. We've had daily, we're being inundated by requests to meet with these vendors to share their experiences. And that hasn't been possible until we finish this project. But we did want to announce today that we are going to have a special national forum for technology providers, startups and long-term vendors in the sector on the 14th of July. More information is going to come out on this shortly, but I'd encourage any of the vendor community to be involved. So the key dates, our survey is going to conclude on the 10th of June. So you've got a few more days yet, and we'd encourage you to input, if you're an industry, if you're in aged or community care, to input into the industry survey. If you're a provider of technology of whatever sort, whether it be telehealth, telecare, personalised technologies to business technologies, we're really interested in getting a sense of the landscape and where we are positioned in this country to respond to the challenges in the future of aged and community care. We've got a real challenge to complete the final report by the 24th of June. We're on target to that, and our great project team, I'd like to acknowledge the efforts of everyone pulling that research together. And so it is your last chance to input. I'd encourage you to make contact with us, either through the survey, through our council website, or in the 2 email addresses there for the council executive and secretariat. That's all from me, and I'm going to actually hand over directly to Dr. Kate Barnett. Dr. Barnett has been taking the lead on the research of the program and has been involved in the council work in many aspects over a number of years. Thank you, Kate.
Thank you, Anne, and good morning, everyone. My job today is to walk you through some key messages that are coming out of the environmental scan. Georgie, are you controlling the PowerPoint or am I? Oh, there we go. Okay, thank you. We have got these 5 areas that we've explained to you before. So today I'm just going to speak briefly to the final 3, the ones that are highlighted in blue. Thanks, Georgie. So as our previous speakers have all said, the impact of COVID on the uptake of technology has been massive, and we're trying to determine to what extent that is occurring in aged care. We certainly have a lot more information about the impact on the health sector. I think the key thing, and one of the key messages, is about competing incentives and disincentives. And what we're hearing from health practitioners in particular is that the previous disincentives of fears of not providing care in a fully professional manner, of observing duty of care because technology would perhaps not allow you to do that, has been overridden by this incentive to avoid infection and to overcome barriers of physical distance, and that's kind of outruled the other. The variation in technology uptake because of COVID is quite significant. It's ranging from extreme failure to engage to people really jumping into the water feet first. What we want to find out is whether or not telehealth and telecare are going to remain part of core service provision as a result of COVID, and I'll say a bit more about that later. Thank you, Georgie. So, in terms of telemedicine, telehealth, we've had some welcome government incentives here with Medicare items for telehealth being created either by telephone or video technology. We would argue that telephone engagement's not really telehealth, but there you go. And there's also been some recent incentives for aged care to, particularly with the Commonwealth Home Support Program allocation for unspent monies for people to purchase monitoring technology, and that's just been expanded a little in the last day or so. So one of the things we're going to look at, and we'll be very interested to find out, is whether this incentive from the Commonwealth Government for the CHIS program, what kind of response there's been from aged care providers to that, because there's certainly an adequate supply of very good monitoring technology out there. We have heard a lot about the Medicare items increasing the uptake of telehealth, but as George Margelis indicated, when you drill down, and research that's drilled down by Outcome Health, which is a group that looks at primary health network providers in Victoria and New South Wales, they have found that the video part of the uptake's actually only been around 2%, which is very, very low. So one of the questions we're looking at and gathering data on is whether the Medicare items have seen an increase in virtual consultation by physicians in residential aged care, and we'll be looking at some MBS data to work that out. Next one, thank you, Georgie. So, key take-home message, listening to webinars with practitioners, talking to people, looking at some of the very early research that is coming out, is that it's not so much the technology. There's a lot of technology out there that is quite fit for purpose, but what practitioners are telling us is that it's designing it in such a way that it integrates seamlessly, if you like, into workflows. And we've seen some very good co-design practice between vendors and providers in health anyway, where they're actually going beyond co-designing a technology, but also co-designing a way to integrate this technology into day-to-day processes. And one of the ways that's been really clear to us is looking at virtual delivery by primary health care and allied health, is the importance and the important role of triage and using telehealth for triaging and working out which patients should, say, come in physically for care and which ones can be assisted virtually. We're picking up valuable lessons about the known there have always been known barriers around infrastructure like connectivity and interoperability. Gavin's going to mention some of that when he speaks after me. In the healthcare field, there's a lot of predictions that virtual care will continue to be part of primary healthcare, assuming that these newly introduced Medicare items continue after September. But what we're also very interested in is whether the same is going to apply in the aged care sector. Thank you, Georgie. If we look at, and another thing I'd just quickly like to say is, will they or will they not continue to play a core role? It will be patchy, as has the uptake. But what we're finding is that in part uptake is due to the previous technology readiness of a provider. So for example, some of the GP practices that have engaged in telehealth, many of them already had online websites, so that there was already a degree of readiness and engagement with technology that they were just able to run with. We're getting a little bit of information coming through in the research that consumers can be driving this, and it tends to be younger consumers actually asking their GPs, for example, for a virtual consultation. So just to finally wipe, it's very hard to do this in 5 minutes, but the area of safety in the smart home, one of the take-home messages is a blurring of the boundaries that we've been seeing before COVID between smart home technology that was developed by technology specialists, not necessarily with care in mind, or making people even be more independent. It's more about having smart living and convenience and so forth. But once you've got on what we have had on the other side, telecare technologies and systems that are purely designed to provide care in the home in particular. So we're seeing over time a merging of the boundaries between those two types of technology because of the outcomes that they achieve, which is greater independence and more control by consumers. The other nice thing it's showing is a blurring of the boundaries, I could put it this way, between care and daily living. And what I mean by that is that if you're an older person and you want to continue living your life, if you see yourself entirely as say a care client of some kind, your whole life, your whole day gets organized around appointments and when people will come and look after you. When you come in through the door of smart home technology, it's more about how can I live more independently, and care and support become more merged rather than separate. We could have a whole webinar on that. The importance of smart home technology too is it is encouraging consumers to have the infrastructure for telecare in their homes. We've also seen, more broadly, uptake with smartphones and apps that are also encouraging people to have the necessary infrastructure to participate in telecare and also to take greater ownership of their own care and well-being. That final message there is about the importance of bringing together end users, and that's the person themselves, their family, care providers, working with technology vendors and others to co-design not just the product, but also how it will be embedded in the home in such a way that it's used seamlessly. Same sort of message as what we said about how you embed this technology into daily work processes and workflows. And of course, the key to that is going to be, and we already have many of them, really strong working relationships and partnerships between technology vendors and aged care providers. And just the last slide, thank you, Georgie. Part of all of this is looking at surveillance and monitoring technologies. And of course, the potential of these to provide better care outcomes, to be able to predict health and care needs as well as ensuring safety, is massive. People tend to think of surveillance and monitoring in terms of video cameras, and I suppose a lot of that's been about the heightened awareness around some of the abuses of care that were occurring in some residential facilities here. But those technologies are only one of a small number, and we are very interested in looking, for example, at the role of more unobtrusive sensors, including artificial intelligence enabled sensors, because of their ability to understand normal patterns of health and daily living and to predict changes in that health status and in safety. The final point I want to make is that, of course, not just in this area of surveillance and monitoring, but with all of the technologies that we want to integrate to make better lives for older people, is being very aware of the ethical implications. And there's been a lot of work done on that as well, and highlighting the importance of taking a rights-based approach for the older person into integrating technology into their daily lives and into the care processes. Thank you, everyone. I will hand over to Gavin Tomlins now. Thank you.
Good morning, Gavin Tomlins here. Welcome on board. This morning I'm going to give you a brief overview of what the Council and the project team have been doing around our interoperability and common infrastructure projects. I found it rather interesting listening from an international perspective, the reinforcement for the need of such work, especially how Malcolm reinforced the need to look at health in new eyes in terms of the crisis that's just emerged. I did find it rather interesting that Adriana also made references to around some of the challenges and reticences of new technologies and how they sort of interact. And then looking at how Greg's used that sort of research data and again, how that interoperability in communication can be the underlying piece. Georgie, can you move to the next slide, please? So I guess if I make reference back to the technology roadmap that basically outlined that technology enabled operation, business and communication systems being destination number one. Georgie, can you please move? Next slide, please. I guess within that, we basically had a look at the lack of processes and protocols for data exchange and the collaborative delivery of care, the lack of interoperability within the aged care system and across sectors, and the need for that sort of system operability. I guess during the current crisis, we've had new data sets and new ways of needing to report data. So it sort of reinforces that particular message on the need to have a sort of common standard and information and how we interchange and exchange that data. Next slide, please, Georgie. The team sort of has been looking at through its various forums and across the CARE-IT that the industry has basically created silos through sort of funding arrangements. And I refer back to Malcolm's comment about having a look at the well-being. Next slide, please, Georgie. And the way the current industry seems to have created itself in that lack of interoperability is due to these industry silos where basically, whether it be the residential aged care data set or whether the community care data set sort of being in isolation and there not being any data interchange. Next slide, please. I guess putting it into a very simplistic thing is like, how can one take a client name from the government portal, bring it down into their client system, then use it with other different providers? So the project team and the IT Council sort of been exploring this avenue via the CARE-IT survey. Next slide, please, Georgie. Within our particular survey, we went into in-depth to have a look at the various analysis and the reportings to the government portals. I think in all, we've sort of done some investigation into the different 25 portals to try and establish what the maturity level of the organisations are and where they are into that journey. We've had a look at the various data sets and the reporting mechanisms and the capability. So we do that from a service provider perspective. Next slide, Georgie. And we've also drilled down and asked the vendors what capabilities do they have and what can they provide. So whether they provide APIs, whether that's private or public, and looking at that interoperability from around that reporting perspective. It's rather interesting, I guess, the feedback. We sort of look at why does it take one organisation 1 hour to do a report as opposed to 100 hours for other organisations. So trying to understand what's there, what's available within the marketplace and the industry at this point in time. Next slide, please, Georgie. I guess the council and the project team really have been sort of focusing on the different levels of digital maturity and how we can sort of address that within the industry. Looking at the ability of how we can sort of translate and use that data across the systems, and basically looking from a industry perspective and a research perspective, why isn't there a common data set, or what are the barriers and hurdles being utilised here? Information reports coming in are varied in terms of the maturity of organisations. We've got examples where certain service providers have up to 60,000 residents of clinical data that they can sort of draw upon. So looking at the different way that information is being used and how we can do that across the industry and sort of replicate those models as case studies, as Anne's sort of spoken about. Next slide, Georgie. So the ultimate goal here is obviously the council and the CARE-IT project is looking at how we can utilise this data to reduce the administration overhead and obviously go for that holy grail. Like listening to Greg's presentation, how can we use that sort of semantic information to basically come up with some sort of knowledge base and new industry outcomes. Next slide, Georgie. I guess further to this, there is a focus on the B2G and B2B interactions. And we're also, though, this time been drilling down a bit further around the particular data sets and what that actually means and to what's being presented. Next slide, Georgie. Sorry, Georgie, next slide. With a particular focus around the data sets. And we have had inquiries from the Royal Commission as to what those industry data sets are. So the council and the project team have been sort of looking at what data is being used and what the time is behind it. So we have actually had a look at the National Aged Care Quality Indicators around pressure industries and physical restraints and ungained weight loss, but also trying to understand within the industry and service providers who actually has that automated, what systems and data are being provided without little interaction. We actually are trying to quantify the time that it's actually used. Again, we have sort of varying amounts between each week in terms of the time and usage. Again, we look at the digital literacy levels of the various providers. If we have a look at, there's some very good comprehensive documentation that have been provided to service providers, but there's around 100 pages of technical specifications. And those small aged care providers who don't necessarily have the systems, how are they coping in submission of that information? And we also go through the complete continuum of care. We're looking at the regional assessment services and everything down to the WAGA report as well. Next slide, please, Georgie. Next slide, please, Georgie. And I guess the final thing is we're trying to get to this situation at the moment, have a look at that data and how we can actually add value and provide context. So within the CARE-IT survey at the moment, there is a number of different journeys from people where they're reporting, whether they be at that level and how can we exchange PDFs. Like in response to, we have question sets around the current COVID situation. We're finding that some people still providing information on paper and pen, which is an effective mechanism, whereas some of the more advanced providers and service providers of software have already integrated their software questions and assessments into the systems, and how can we extract that data for better usage? Obviously with that holy grail, which what Greg was saying on how can we use this data to deliver better care. I encourage everyone to basically partake in the CARE-IT survey at this present point in time, and also speak to their service providers on how they can best utilise and complete that survey as well for further interoperability. Thank you.
Excellent. Thanks very much, Gavin. So what we'll do is we'll just we'll bring up on screen everyone's vision. We'll so we can have a bit of a panel chat here. It's going to be very quick because we've got just a short amount of time before we close out. But what I can assure you is there's been a lot of questions in the chat function, and some of those are being picked up already. There was interest about someone wanting to introduce smart technologies into their facility, and Dr. Malcolm Fisk has an amazing experience in that, as do many of our panelists. So we'll pick up some of those questions. So a few questions that have come up there, and I might get Anne and George to chime in on this one first up, because it was a similar sort of question to what we had in our first forum. And that question comes from one of our participants asking, why are people living in aged care facilities not involved in any of the research, including being asked for their view of the lockdown? So can you just, perhaps I'll come to you, George, first, and then Anne, just pick up on the full breadth of the research that's going on.
Well, yeah, thanks for that question. And it is a great question, and it is one that we are actively looking at solving. And Anne will probably touch on this in more detail, but one of the projects we are working with is looking at living labs. So using aged care facilities, not just as data sources for reports, but actual laboratories to see how new solutions work best, what solutions will work, what the providers need, what the residents need, and developing on that model. So the living ladders model, I think, is going to be a great way to push that forward, get residents actively involved in the research. To date, there's been a whole bunch of challenges about how that's done, and Anne's probably more an expert on this. I'll hand over to Anne.
Anne?
Thanks, George. Thanks, Aaron. It is important to note that our research project was formed, scoped, and grounded in the pre-COVID era. We just happened to commence the project as COVID was emerging as the massive issue that it has, and that we've seen that massive transformation of the sector's uptake of technology and innovation as a result. But our survey is targeted at a benchmark in time of where the sector is and where the vendor community is in terms of its appetite, ability to interact with technology, and to its business processes, to its maturity of interfaces with consumers. Doing that piece of research that's been suggested is obvious and apparent, and probably should stand alone as a separate piece of research, and I think the council would really be behind that. We know that the dilemmas for individuals and their families have been immense during the time of lockdown. In some instances, technology has helped, but in others, it hasn't contributed to lowering the stress of either the individual or the families. So yes, I think that that's an important piece of research. It's not a focus on this report because it was reframed when we weren't in a COVID time, and we've just tried to modify and respond and capture that moment in time that's occurred because of COVID.
So, Anne, I mean, this is the critical part of the forums of the council, of everyone coming together, and you can just see the collective intelligence and a lot of people actually sharing and answering questions online before they're even brought here. That's exactly the sort of commentary that you're looking for, aren't you, as the council, and in feeding into these research questions, which you can then focus on over time.
That's correct, Aaron. We're really open to feedback. We've been responding to consumer groups. We've been engaging with consumer groups. We've had many consumer groups, from mental health groups to more broader health groups, on today's webinar and on other webinars. So we really encourage you to be involved. The survey is not specific to carers and their families, but look, it's obvious that that's a whole other piece of research that should and could be done.
Great. Look, I'm very conscious of time. We've packed a lot into a very short space of time, so I just want to highlight a couple of these questions, which we'll pick up after the forum finishes. And indeed, as I said, this recording of this session will also be online on the website too. So things like what can be done to help smaller and regional rural-based aged care providers to better use tech in their services. That's exactly what I've seen the council doing. That's exactly what's been occurring at conferences like ACIITC. So I encourage the participant who asked that question to really engage with that group. There's a lot of peer-to-peer assistance going on. And you probably just touched on this, but COVID-19, residents in facilities feeling more isolated and stressed during this time. So any kind of technologies being deployed in aged care homes to address these issues. Again, I've seen lots of great technologies being deployed and used to actually break down some of those barriers, particularly in the startups that are also showcased at events like ACIITC. So I just want to come very quickly, probably a really quick comment, Kate, from you, George, Gavin and Anne, to finish us off. But what leading technologies, and I know this is going to be difficult to probably pick one, but what leading technologies that you think should be adopted for enhancing residents' social wellbeing during this time? So if you can just be nice and quick, Kate, I might come to you. I hope I've left you enough time to have a think about that one, but probably your headline top technology that you think should be something that's been quite ubiquitous and being rolled out.
Look, I think there's no single technology you know, that you could say would support social wellbeing. It's going to be like a jigsaw puzzle of several different ones that support consumers, but it's, you know, it includes apps, it includes sensor monitoring, it includes engagement programs that people can be involved in. So monitoring programs that are unobtrusive. Aaron, there's too many out there.
No, I think, Kate, you've actually answered it very well, because from what I see, it's the systems approach that works, and it's the workforce, and it's not just the technology, and that's what we talk about again and again. So that's probably not a bad. I'm just very conscious of time here, so that's probably not a bad point to finish on. So
what I think is probably the most important thing is using our own brains and our imagination, so we can actually utilize what we have most effectively. So don't try to find the right technology, grab what you have, use your imagination, experiment, and make it into something that works. That I found that to be the most effective way of using it.
And the opportunities that co-design with clients themselves and families and broader community members, we're seeing that more and more being brought to prominence, and the work that the Council's doing on a National Aged Care Living Lab will also enhance and give the ability for more people to be involved in that.
Great, Anne. And look, Gavin, I'll come to you for the last comment there. I was very interested in your discussion around interoperability and the silo question that Malcolm posed in the very early stages there, and sort of this coming together potentially of you know, social healthcare, you know, all of the different sectors. I'm very interested to hear your comment on that.
So I guess if we have a look in the current crisis around COVID and around workforce credentialing, obviously there is a need to basically understand who has what in terms of vaccinations or who's been in contact. That's just a great example of interoperability, but the industry coming together as a whole on how they can share data. So there's a bit of work with the council and some initiatives there, but obviously having a look at it from an industry-wide perspective rather than just looking at your organisation and how we can collaborate together.
Look, a huge amount of questions. As I said, we will pick up all these questions. I absolutely assure you of that. And again, this is what this is all about. I encourage you to go to the vendor survey, to look at the roadmap if you haven't already. I want to thank all of our speakers, Dr. Malcolm Fisk, Ms. Adriana Shikaru, Professor Greg Alexander, of course, Ms. Anne Livingston, Dr. Kate Barnett, and Mr. Gavin Tomlins. I want to encourage you to visit the Aged Care Industry Information Technology Council website. All that information is up in your chat function. The full copy of this forum, the recorded copy, will be available there for any of your colleagues who may have missed it, or if you want to go back and check that information. We'll circulate a survey after this so we can keep on improving these sessions. So any suggestions you've got, we really would love you to just take the time to fill out that survey. So again, thank you so much to all of our speakers, but thank you most of all to you, the participants, for engaging so fully in this, our second of the quarterly forums for the ACIITC. So thank you very much, everyone. Enjoy your day and look forward to your continued engagement as we build the best possible information and the best possible roadmap into the future. Thanks so much.
Thank you, everyone.